As healthcare providers across all disciplines reflect on what reconciliation looks like in our respective specialties, we're becoming more aware that emergency departments do not meet the needs of Indigenous peoples the same way we meet that of non-Indigenous peoples. These healthcare disparities can lead to poor experiences, misdiagnoses, and inadequate treatment. In order to make the ED perform as it should for Indigenous patients, we need to actively look for where healthcare disparities can originate within the ED. We'll explore ways to integrate the mitigation of healthcare disparities into our clinical process in the ED. I have no conflicts of interest to disclose. This presentation is recorded on the traditional and unceded territories of the Kwantlen, Katzie, and Matsqui First Nations. I do not possess lived experience from an Indigenous perspective. This presentation is made from the perspective of a person without lived experience for other providers without lived experience. While immensely valuable, we do not have an Indigenous co-presenter today. We seek to critically reflect upon and draw lessons from the tremendous input Indigenous voices have already contributed to literature. Speaking about Indigenous health from the lens of a non-Indigenous healthcare provider is not an attempt to add validity to Indigenous voices. These voices are intrinsically valid and do not require further validation by persons without lived experience. This presentation contained material that benefited from the expert input of Dr. Terry Aldred and Elder Lucy Duncan. Evidence suggests that emergency departments play a significant role in the healthcare of Indigenous patients. This is not to say that there is necessarily a preference for seeking care in the ED. There is a common sentiment of not wishing to be in the emergency department unless it is the very last resort due to concerns about negative experiences. The In Plain Sight report was released in BC in 2020 and found that Indigenous patients were significantly more likely to encounter adverse experiences when accessing healthcare. Not surprisingly, Indigenous peoples were found to be over 3 times more likely to feel not at all safe in the ED compared to non-Indigenous peoples. The sources of these unsafe experiences encompass numerous disciplines and services that span from the very entry into the ED to after discharge. In addition to disparities in the care experience, there are measurable differences in the clinical care that is provided to Indigenous patients. In a recent study, First Nations patients were less likely to receive a CTAS score of 1 or 2 than non-First Nations patients on the number of presenting complaints, including long bone fractures. An older study from 2013 compared geographic areas with high percentage of First Nations populations with those with lower First Nations populations. The former has lower rates of PCI for acute myocardial infarctions even after correcting for rurality. In summary, the emergency department may not be fully meeting the needs of Indigenous patients. This is suggested by the fact that self-initiated discharge rates are higher amongst First Nations patients. With more evidence illustrating the healthcare disparities affecting Indigenous patients, clinicians are becoming more aware of the roles they play in reconciliation. There is increasing interest in cultural safety training as well as education on colonialism in Canada. What has been relatively less common are discussions on the gaps within our clinical processes in emergency medicine that could give rise to healthcare disparities. In order for there to be observable healthcare disparities, our clinical process in the ED must not be as effective in serving Indigenous patients as they are for non-Indigenous patients. What I hope to do today is to explore how specific aspects of our clinical encounters could require optimization in order to better meet the needs of Indigenous patients in our very next clinical encounter. I'll share some ideas on specific actions to consider taking as a clinician at various points of the encounter. This is by no means suggesting that these are the best ways or the only ways to close these gaps. The aim is to critically examine where our care processes may not be meeting the needs of Indigenous patients in hopes of promoting further discussion on this topic. In emergency medicine, our clinical suspicion can begin to form even prior to meeting the patient. We then assess the patient through history, physical exam, and investigations. We then offer a management plan that may begin in the ED and continue into their disposition. We'll examine how this process could be impaired, leading to misdiagnosis and inadequate treatment. Our clinical suspicion can be impaired when we fail to recognize the presence of biases and stereotypes that may inappropriately lower our level of suspicion. We may also miss the opportunity to recognize that there is a higher overall pretest probability of clinically significant conditions. During our assessment, we may establish insufficient rapport with our patients. This may limit the history that we're able to gather, and we may not earn enough trust for the patient to permit adequate physical examination. This may further lead to a lack of appropriate investigations. In managing patients, a lack of rapport may decrease confidence in our advice, leading to a lack of acceptance of our treatment. We may also contribute to a lack of buy-in from the patient by demonstrating a lack of understanding of personal context. We may neglect to connect patients with appropriate resources or proactively address barriers. We may also fail to account for the poor access to primary care, leading to poor follow-up. All of these may contribute to the patient's needs being unmet or inadequately met in the emergency department. We'll explore these elements in more detail. We need to recognize that the impairment of our clinical process may arise due to the impact of implicit bias and manifestations of trauma. Each of these two topics could benefit from detailed examination, which are outside of this presentation's scope. However, we'll introduce these two topics briefly. Implicit bias involves association outside our conscious awareness and control. It can link a group and a stereotype and lead to negative evaluation of a person on the basis of irrelevant characteristics. It may not correspond with what the individual believes outwardly. For example, a person may explicitly believe in multiculturalism in Canada. However, there may be implicit tendencies to consider Caucasian people to be more Canadian. There is evidence that health professionals exhibit the same level of implicit bias as the general population, and there is significant relationship between implicit bias and lower quality of care. Evidence suggests that the ED environment is conducive to implicit bias. For a more detailed examination of this topic, consider referring to this presentation. Trauma may manifest in different ways. While the main reason for a patient's presentation may not be related to trauma, it may still affect the presentation. Manifestations of trauma may be misinterpreted by providers as a sign of mental illness or lead to difficult interactions in the clinical setting or even ejections from care. Working effectively with patients affected by trauma requires providers to be aware of the potential impact of trauma. This can then lead to reframing of how we perceive and relate to the patient. For instance, instead of viewing a patient as being manipulative, we can understand that the patient may have difficulty asking directly for what they want. For more information on trauma-informed practice, consider the practice guide prepared by the Center of Excellence for Women's Health. We begin to form our clinical suspicion even before first meeting the patient using data points such as age, biological sex, triage history, and chief complaint. Our clinical suspicion may then affect how we assess and manage patients. We need to recognize that our clinical suspicion could be inappropriately decreased when working with Indigenous patients. We can ensure that we maintain an appropriate level of clinical suspicion by recognizing bias from external sources, recognizing the impact of stereotypes, and considering the pretest probability. Triage can determine the physical space that patients are allocated, how quickly they're seen by a physician, whether any initial investigations and treatments are initiated, and the frequency of nursing care. This can take place all before the emergency physician sees the patient. The In Plain Sight report found that First Nations patients are less likely to receive an urgent triage acuity score. Interestingly, it also found that those with lower triage acuity scores had a higher admission rate compared to non-Indigenous patients, raising the potential that the initial triaging may have underestimated patient need. As a clinician, we may need to be aware of this phenomenon. If we recognize that the patient we're seeing seems to require a higher acuity care setting than they were initially allocated, we may need to advocate for a change in care setting. The In Plain Sight report also found evidence of widespread Indigenous-specific stereotypes throughout the BC health system. Not only do these stereotypes contribute to unsafe healthcare experiences, they also may have an impact on provider decision-making. Previous research has shown that clinicians are susceptible to being influenced by race when considering medical diagnoses. In one study, clinicians were asked to read vignettes and associate them with medical diagnoses. When subliminally primed with black faces, clinicians made stronger association with racially stereotypical diseases. It is therefore possible that the prevalence of Indigenous-specific stereotypes can have an impact on our diagnostic considerations. As clinicians, we may need to audit our own clinical decision-making to ensure that the data points that we are relying on to make decisions are based on facts pertaining to our specific patient rather than stereotypes or assumptions. Stereotypes may lead providers to seek stereotype confirmation from the patient. This may cause us to overvalue the patient's behavior and attitude as factors contributing to their illness. Implicitly, this may cause us to internally demand patients to prove themselves worthy of care. We may then miss more relevant factors contributing to the patient's illness and damage our therapeutic relationship in the process, leading to perpetuation of the patient's unmet health needs. Unfortunately, these needs may then further contribute to the patient's stereotype. Structural violence affecting Indigenous peoples both currently and historically have resulted in higher prevalence of adverse determinants of health. There is evidence that using determinants of health as risk predictor for all-cause hospitalization and death was as predictive as conventional biomedical risk predictors. As such, when working with patients living with adverse determinants of health, the clinician may need to be more concerned that there may be an acute underlying condition. Next, we'll explore some potential areas where our assessment process could be optimized. While clinicians have been trained on patient-centered care methods, clinicians are also less likely to use them during encounters with patients of racial minorities. Patients from minority groups are less likely to share their health narratives with the clinician. These factors can adversely affect patient assessment. While patient-centered care and trauma-informed practice will be best regarded as universal precaution in emergency medicine, clinicians may need to especially ensure their use when working with Indigenous patients. Indigenous patients may be coming into the encounter with previous personal or vicarious negative experiences in healthcare. As a result, we likely should not expect or assume trust, but rather make earning trust a distinct clinical objective right at the start of every encounter. If patients do refer to previous negative experiences, empathetic and respectful acknowledgement would likely do more to earn trust than responses that could be interpreted as defensive or dismissive. In each clinical encounter, consider making sure that the patient knows that you have seen them as a human being. In the ED, it is common to focus on taking the steps to move the patient through their ED journey without necessarily explaining this to the patient in a timely manner. For patients facing structural marginalization, this may eventually lead to the patient disengaging as they begin to wonder whether their needs will be met. It may therefore be especially important to convey the plan and progress. As part of building trust, patients may appreciate transparency and consistency. Consider patients' perception and recognize that unaddressed negative perceptions may be just as damaging regardless of whether there was bad intent and whether it actually caused any bad outcome. Preface sensitive questions and exams with an explanation on why it is relevant. Ensure that all promises are kept and that patients are not made to feel guilty for provider errors. Avoid giving the patient the impression that they are getting the runaround. Even with the best intentions, our use of language has the potential to cause harm due to the burden of anti-Indigenous stereotypes. While living circumstances and substance use are both common elements of the social history, if asked in close proximity to each other, it can leave the impression that the clinician is making an association between indigeneity and substance use. To avoid this association, consider reordering the category of history taking such that substance inquiry follows medication use. This can then be separated from the social history by inquiring about allergies. We can also preface our inquiries with offering an explanation on why this information is helpful. Another consideration around language is being cautious of benign assumptions. Some physicians offer an exaggerated estimation when inquiring about the amount of alcohol use to make patients feel more comfortable when disclosing use at a lower amount. However, this may not be benign when working with Indigenous patients given the prevalence of damaging stereotypes. Because of the phenomenon of stereotype threat and living with the burden of history, clinicians may need to be aware that silence may not mean agreement, consent, or lack of concern. Consider pausing and making space for patients to respond, or following up with a more open-ended question. Rapid focus on diagnosis and management prior to achieving common ground may impair trust. Colonialism and trauma make power differential an especially important consideration in our clinical encounters. Previous qualitative research has identified that clinicians should do our best to avoid approaches that can be perceived as prescriptive, authoritarian, and coercive in order to avoid exacerbating the negative impact of power differential. Due to complex personal context, the impact of colonialism, and systemic barriers, Indigenous patients may benefit from more time in order to have meaningful clinical dialogue. Budgeting additional time and viewing this use of time as legitimate from the very beginning decreases the stress on both the provider and the patient. In ED, time is the most valuable commodity. However, we intuitively know that patient context can make two similar presentations take different amounts of time to assess and treat. For example, two patients presenting with lacerations of the same body part, with one being from a sporting accident and another from intimate partner violence, will take different amounts of time and resources to assess and treat. It is possible to ultimately run out of time that is available. It is reasonable to acknowledge to the patient that there seems to be needs that remain unmet and to refer the patient to an appropriate service for follow-up. Finally, we need to be aware that there is evidence of disparity in the rates of investigation of racial minorities. If we decide that investigations are not necessary, we may need to carefully review the decision to ensure that it is not informed by assumptions or stereotypes. We may want to ensure that adequate rapport was built such that patients are less likely to have information that they have not yet shared. Finally, we'll explore some ways we could consider optimizing our management plans. Part of meeting people's needs is addressing pain. Research shows that racial minorities are less likely to receive opioid medications. They're also less likely to receive a prescription for analgesics. Concerns around undertreatment of pain amongst Indigenous patients in Canada is also well documented in previous research. Some strategies to consider include using self-rated pain scale to assess pain or involving pain consultant services. To ensure that my decision to initiate pain management for a specific patient is not overridden by the discretion of another provider, I consider ordering PRN medication with the specification first dose ASAP. Consider acknowledging the patient's strength and resilience by making genuine, specific, and relevant affirmations. Given the limited time in the emergency department, supporting cultural practices and care likely entails non-interference rather than active facilitation. Consider that some patients may have larger circles of care that may include elders or extended family members. This may enhance collateral information, increase adherence, and improve continuity of care. As providers, we may need to consider the real or perceived impact of our policies and physical environments in creating barriers for patients. For instance, providers' emphasis on patient choice and responsibility can serve to alienate patients whose choices are affected by upstream systemic barriers. Policies such as form completion fees can disproportionately disadvantage patients with limited means. Limiting the number of people involved in patient care could also be disruptive to cultural and family needs. To offer supports on determinants of health, consider using the poverty tool. First Nations patients may be eligible for First Nation Health Authority health benefits, with coverage for vision, dental care, medication, medical travel, medical devices, and mental health. This can be helpful to take advantage of, especially in those who may otherwise have limited means. Patients with First Nations Health Authority benefits are eligible for coverage under Plan W. Certain medications may not be covered completely, which can be verified on the formulary. Patients with FNHA health benefits are also eligible for coverage on a number of over-the-counter medications with a prescription from the physician. Please refer to the website for a complete list. Where appropriate, consider connecting patients with 24/7 mental health support. The Hope for Wellness helpline also has access to support in Cree, Ojibwe, and Inuktitut during specific hours. Psychiatric consultation and addiction services are also available for First Nations patients. Additional supports are available for survivors of residential schools. As mentioned earlier, there is a higher rate among Indigenous patients of self-initiated discharge. This likely reflects barriers in care and unsafe experiences rather than true patient preference. Regardless of the cause, it reflects an unmet need. This would likely be a target where interventions could be beneficial. For patients considering self-initiated discharge, providers could work to identify the reason, address any concerns or barriers, or help meet immediate needs. Typically, when patients are refusing care, we look at whether the patient has capacity to refuse and whether they demonstrate an understanding of the risk and benefits. However, for all structurally marginalized patients, it may be important to add to the criteria whether we have earned the patient's trust and whether the patient feels safe. If this criteria has not been met, we may need to make another effort to better understand and address any barriers. Consider helping to improve continuity of care by referring patients for attachment. For patients without family physicians, consider making an alternate follow-up plan rather than deferring tasks to non-existent family physicians. To enhance communication with support systems and to provide useful health information, consider providing written information to patients about their ED visit, especially if there is no access to a regular primary care provider. We've critically explored our ED clinical process with a lens of mitigating healthcare disparities. I'd like to end on these two thoughts. Systemic racism may not feel racist or overtly discriminatory. It may simply feel like offering routine care, yet the care does not adequately address a barrier that applies disproportionately to a specific population. As such, systemic racism is capable of causing harm independent of the presence or absence of ill will in the providers. We need to recognize that the current gap in health outcomes between Indigenous and non-Indigenous patients receive contribution from how we currently provide care in the ED. In order to improve population-wide health outcomes, we need to increase our standard of care beyond what's currently common. Currently, the care provided to Indigenous patients cannot be considered equal to non-Indigenous patients. However, equality is not the goal. Providing equal care will continue to perpetuate many healthcare disparities due to unequal systemic barriers. Meeting different people's needs may require different amounts of resources. Ultimately, we will require larger systemic shifts to address underlying systemic barriers in order to achieve justice. Throughout our clinical encounters in the ED, there are many opportunities to mitigate healthcare disparities. Each interaction with an Indigenous patient is an opportunity to address these disparities and to contribute to reconciliation in a concrete way. Thank you for your kind attention.